topic is going to be covering more of the information processing side of the central nervous system because today we're going to be talking about the spinal cord and spinal reflexes. It's Dr. Snyder here at Indian River State College with your Unit 5 discussion about the nervous system. Let's dive into it. So when it comes to chapter 12, we of course are talking about the spinal cord and all of the different reflexes that are going to be seen in the spinal cord physiology. We'll start off with taking a broad overview of the structure of the spinal cord, which is going to include 31 total segments, and that includes 31 total pairs of spinal nerves, because we do have one pair of spinal nerves per segment or per level throughout the spinal cord. Now, the entire spinal cord is going to be about 45 centimeters or 18 inches long, if we're American, of course, and it's going to end around the L1 to L2 vertebral level. The ending here at that L1, L2 vertebral level is going to be what we call the conus medullaris. The conus medullaris is going to be down right around here. And when I mean the spinal cord ends in this region of the spine, it's not to say that all of the different structures completely stop. Instead, we are going to see at this conus medullaris, the spinal cord will then divide into multiple different segments or multiple different nerves that will then travel down the lumbar spine in what is called the cauda equina, which roughly translates to the horse's mane, because it does rather look, or the horse's tail rather, because it does rather look like that fur, that hair that you see on a horse. And then, of course, when we are talking about the spinal cord itself, though, important things to note are that the cervical spinal cord is going to be the largest section of the spinal cord. And it makes sense when you think about how all of the information is going to be distributed as it goes up and down the spinal cord, because the cervical spinal cord has to carry information from the lower limbs, the trunk of the body, and the upper limbs. Whereas when we move down to the thoracic region of the spinal cord, this region of the spinal cord only really needs to carry the information for the trunk of the body and the lower limbs, because all of the information for the upper limbs does not actually come into play with the thoracic spinal cord. It goes straight to the cervical spinal cord. And then the same kind of process can be seen when it comes to the lumbar spinal cord, or the lumbar region of the spinal cord, because this is going to be where we're carrying information about the lower limbs rather than everything from the upper limbs, the trunk, and the lower limbs. Now, on the topic of the spinal cord here, note that when we are talking about the spinal nerves, we are talking about these small areas of nervous tissue that are going to be branching off of the spinal cord and then traveling through the body as parts of the peripheral nervous system. Now, keep in mind the numbering system that we use for each of these pairs of spinal nerves, because remember, when we talked about the individual segments in the skeletal system, if you remember, there are going to be 7 total vertebrae in the cervical spine, 12 total vertebrae in the thoracic spine, and 5 total vertebrae in the lumbar spine. However, keep in mind that there are going to be 8 pairs of cervical spinal nerves, and this is because we include the pair of nerves that exit between the base of the occiput and above C1. That is going to be our C1 pair of spinal nerves. And then when we move down to the area between C1 and C2, this is going to be our C2 pair of spinal nerves. And we follow that all the way down until we reach the junction between C7 and T1. The pair of spinal nerves that exit between C7, and T1 will of course be the C8 nerve roots, so that we can compensate for the fact that we're not going to refer to the very top pair of cervical spinal nerves as the C0 spinal nerves, which is usually the designation for the base of the occiput of the skull. Instead, we use the term and call it the C1 nerve root pair and go all the way down to the C8 nerve root pair between the C7 vertebral segment and the T1 vertebral segment. Throughout the rest of the spine, we are going to use the same numbering system per spinal segment. So in the thoracic spine, there are 12 vertebrae and there are 12 pairs of thoracic spinal nerves. So T1 spinal nerve through T12 spinal nerve. And the same kind of process can be seen in the lumbar spine. We have an L1 spinal nerve pair all the way down to our L5 spinal nerve pair. And then, of course, we see the same sort of numbering system for the sacral region, our S1 nerve root, S2 nerve roots, S3 and S4 nerve roots. So that should give you a good idea of why we have this interesting numbering system for our pairs of spinal nerves. Let's take a look next at the cross-section of our spinal cord. So we have up on top, we have our cross-section of the cervical spinal cord, and then on the bottom, we have our cross-section of the thoracic spinal cord. Now, you can see this by looking at, this is our segment C3 region of the spinal cord up top, and our segment T3 region of the spinal cord down on the bottom. Now, these are not quite to scale. They've been enlarged, or the bottom part has been enlarged to show more of the detail. So that's why, even though on the previous slide I mentioned that the cervical spinal cord is larger, even that's going to be the reason for why we're looking at this picture here and going, well, wait, it looks like the thoracic spinal cord is bigger. That's actually not true. These are not quite to scale in reference to each other. So the first thing to note of our spinal cord structure is that we have the differentiation between white matter and gray matter. The white matter is, if you remember from our previous chapter, going to be the area which is heavy in lots of myelin. That's because these are going to be the areas, the white matter areas, are going to be our areas of heavily myelinated axons, versus the gray matter, which is going to be our area of unmyelinated cell bodies. So the gray matter is going to be where many of the different synapses are occurring between all of our different axons as they reach those portions of the gray matter. Now, when it comes to what we're looking at through here, though, some key landmarks to note, of course, are going to be the central canal right in the middle. This is going to be the area through which cerebrospinal fluid actually flows up and down inside the spinal cord. We do also have a fair amount of cerebrospinal fluid flowing around just on the outside of the spinal cord in what we call the subarachnoid space. But when we take a look next at the anterior median fissure and the posterior median sulcus, these are going to be key landmarks which help to divide the left and the right portions of the spinal cord. And of course, when we talk about left and right, we are talking again about from the patient's perspective, not our own. So if this is the anterior median fissure, that means this is the portion that is going to be pointed forward. So the patient's left spinal cord is going to be out here, whereas the patient's right spinal cord is going to be out here. So some other key features to note are that we're going to end up seeing these nerve roots branching off of the different segments of the spinal cord, and they're going to branch off through what we call the rootlets that come down through the white matter. As they become the roots, we have a posterior spinal nerve root and an anterior spinal nerve root. And then on the posterior side, we are going to see an enlargement on the nerve root that we call the posterior root ganglion. A ganglion is going to be a portion in the peripheral nervous system through which we see a collection of cell bodies. So this is going to be an area through which the posterior signals will synapse with each other. Now, the reason that we see this enlargement of the cell bodies on the posterior root and not on the anterior side is because the anterior side is going to have that collection of cell bodies found in this enlargement of the gray matter that we see here. And this enlargement of the gray matter is going to be what we call the anterior horn. That is what these outward projections of the gray matter in the spinal cord are going to be referenced by. They are the horns of the gray matter. So we have an anterior horn and a posterior horn that we see right through here. That is going to be our definition of the gray horns, outward projections of the gray matter in the spinal cord. And so in the posterior side, rather than having that enlargement in the gray matter, we simply have it out here in the spinal nerve root versus the anterior side, where our collection of cell bodies will be found in that anterior horn. Other key things to note are that when we get down to the thoracic region of the spinal cord, we have three horns of the gray matter. We have an anterior gray horn, a posterior gray horn, and our intermediate or lateral gray horns. Now, the reason that we have these gray horns in the thoracic spinal cord only, we do not have them in our cervical spinal cord regions and not in the lumbar spinal cord either, because remember, the lumbar spinal cord is just a collection of nerves that flow down through the spinal column. But we have these lateral gray horns that we see right here in the thoracic region because this is going to be the region where the cell bodies that control the autonomic nervous system will reside. And the reason for this is because we need to talk about the divisions that we see in the spinal cord. So let me go ahead and get my pen here. All right. We'll get a nice green color. Perfect. So, in general speaking, for most cases, but not quite all, when we talk about the divisions of the spinal cord, and this is also slightly true for the brain as well, we'll just, instead of using this imaginary line, there's an actual line that we can trace down on the brain. There's a structure called the central sulcus, but that's for the next chapter. For the spinal cord, though, if we take the spinal cord and we draw an imaginary line straight across the lateral equator that we see through here, the structures that we see on the anterior spinal cord will be mostly motor structures. Goodness, that is terrible. Please forgive me. I do not have my mouse with me today, so I'm using a trackpad. Let me try that again. Let me get my motor pathways working here. All right, motor. Motor signals are going to be found on the anterior side of the spinal cord, whereas on the posterior side of the spinal cord, we are mostly going to see sensory pathways. And it's the same when it comes to the brain. Posterior structures will mostly be carrying sensory information, whereas anterior structures will mostly be carrying motor information. So that's a key concept that's going to really help you a lot with understanding more about neurophysiology. So keep that in mind. Posterior structures mostly carry sensory information. Anterior structures mostly carry motor information. So when it comes to the afferents, the ascending signals, they will travel by way of these posterior horns and these posterior sections of white matter, which are going to be further divided into tracts, which we'll talk about more later. And then the anterior horns out on the front. And this includes the motor information that will be carried by those lateral gray horns, because this is going to be the information that tells our internal organs or the viscera whether or not they need to be jumping into that parasympathetic or a sympathetic state. And so just outside the spinal cord next, let's talk about the structures that are going to be known as the meninges. So the meninges are going to be a series of 3 layers that are going to surround and protect the spinal cord, and they will be named from superficial to deep: the dura mater, the arachnoid mater, and the pia mater. The dura mater is, of course, going to be the toughest, most dense outer layer. It's going to be mostly comprised of collagen fibers, and it is going to create most of the protection around the spinal cord. It is also going to include a layer that will actually attach to the spinal cord itself. They are going to be called the denticulate ligaments, which you can actually see in this cross section of a real human spinal cord that we see right over here on this picture. The denticulate ligaments are going to span from the inner layer of the dura mater and then attach to the pia mater at the very deepest portion of the meninges. And the reason we have these denticulate ligaments in place is actually to hold the spinal cord in place within the dura mater and prevent the spinal cord from twisting or having torsional forces inside of that dura mater. That's very, very important because nervous tissue is very sensitive to pressure. The next layer is going to be called the arachnoid mater, or the arachnoid layer, which is going to include a couple of different areas. And this is going to include the subarachnoid space, which is going to be where we see the blood-brain barrier that I mentioned in our previous chapter. And then we have the pia mater. The pia mater is going to be the very innermost, the most deep layer that is just adjacent to the spinal cord. And it's going to be a rather thin, delicate layer made of elastic and collagen fibers that, of course, attach directly to the spinal cord and allow for those denticulate ligaments to have an anchor spot and prevent any torsional forces on the spinal cord. When it comes to just around those meninges, we have what's called the epidural space. The epidural space is going to be found, of course, just outside of the dura mater. That's why we use the term epidural, because epi means above, so we are just outside the dura mater. The epidural space is going to be mostly composed of areolar connective tissue, blood vessels, and adipose tissue. This is going to be the area in which we actually inject an epidural injection when we are talking about needing the use of different painkillers to help with controlling nervous signaling above and below different areas of the spinal cord. We also have the subarachnoid space, of course, found in that arachnoid layer, which is going to be filled with CSF, the blood-brain barrier, and is the area that we use to do what is called a lumbar puncture or a spinal tap, if we have to actually take a sample of the CSF for different laboratory tests, most often or most commonly seen when it comes to testing for meningitis. So meningitis is going to end up, if you break the word down and you know that itis means inflammation, we are talking about inflammation of the meninges. And the meninges, they are going to be continuous throughout the spinal cord and the brain. We are going to call the meninges in the spinal cord the spinal meninges. And then when it comes to the meninges in the brain, we are going to call those the cranial meninges. But when it comes to this meningitis, it will affect both the cranial and spinal meninges. So if we are suspecting meningitis and we need to run a laboratory test and evaluate the CSF flowing throughout those meninges, we of course need to take a sample of that. And we are not going to do so by taking a sample out of the cranium. And we are not going to do so by taking a sample next to the spinal cord. Instead, what we are going to do is we are going to use our knowledge of anatomy. We know that the spinal cord ends above the lumbar region, and we want to make sure that we take our sample from an area which is not at risk of having a puncture of the spinal cord. So we go down to the lower lumbar spine, where we see the cauda equina. And you can see through here those individual nerves of the cauda equina as they float inside that dura mater in all of that CSF. What happens is when we take a needle and we pierce the posterior soft tissue region of the spinal column, and we go into the dura mater with our needle, aquadynamics are going to allow for the fibers of the cauda equina to move out of the way of the needle so that the needle can safely take a sample of CSF without worry, or without too much worry, of damaging those delicate nervous system structures. Excellent representation here, labeling all of the different areas of the spinal cord that I've already covered here. How we end up having the anterior horn is going to include most of our motor nuclei. The lateral horn is going to include our autonomic motor nuclei, the visceral motor nuclei, and the posterior horn, including the sensory nuclei all the way in the back. And then, of course, just around that central canal, we have another area of gray matter, which is going to be our gray commissure. The gray commissure is going to include our axons that will connect the cell bodies from our left and our right gray horns. So that's going to give us an excellent representation about where exactly we can find all of those different nuclei inside the spinal cord. Keeping in mind, remember, that anterior structures will mostly carry motor information, and posterior structures will mostly carry sensory information. Break down this image here, how it has all of our flexors and extensors neatly labeled on this graph that we see right through here. What it means by flexors and extensors, we are talking, of course, about muscles that control flexion, otherwise known as movement in the anterior direction of the sagittal plane, versus extensors, which controls posterior movement in the sagittal plane, except, of course, for when we are talking about the knee joint. The knee joint is going to be the only one that follows the opposite of that structure. The knee joint is going to involve extension when we move anterior in the sagittal plane, and flexion when we move posterior in the sagittal plane. That's the only exception, is the knee joint, but everything else follows. Flexion is anterior in the sagittal plane, and extension is posterior in the sagittal plane. So keep in mind that these colors over here, this green, yellow, and purplish, is going to represent our flexors, and then the green and the reddish colors are going to represent our extensors. It's going to involve the same kind of organization when we take a look at the posterior columns. These posterior columns are going to be these regions that we find in the very posterior side. They are going to also be called the dorsal columns medial lemniscus. Quite the term here. Let me go ahead and just write that down here. The DCMLs for short. Boy, I really wish I had my mouse with me today. DCML. Dorsal column medial lemniscus, also called the posterior columns. And they are going to end up including two sections. They're going to be divided into what is called the fasciculus cuneatus, which is going to be out here, and the fasciculus gracilis. So we'll write that down here. So we've got F for fasciculus. I might just have to give up on this writing thing. Holy. Gracilis. And then, oh goodness, we'll just put a C. Fasciculus cuneatus. There we go. Okay. Now keep in mind that, of course, when we were reviewing the muscular unit, we had a muscle called the gracilis muscle. It's going to be found in the lower limb, remember? So Because we have this term, the fasciculus gracilis, this is going to be the portion of the dorsal columns which carries sensory information from the lower limbs. And then, of course, we have the fasciculus cuneatus, which is going to carry sensory information from the upper limbs. So that's going to be our division of the dorsal columns in the posterior side of the spinal cord. Next, at the spinal nerve structure. So, of course, we've said there are 31 total pairs of spinal nerves, and they are going to exist within 3 different layers of connective tissue. So we end up, when it follows quite similar, or quite a similar pattern to the skeletal muscle fibers as well. And just like when it comes to the different layers that we see in our skeletal muscles, how there is going to be the muscle belly and then the fascicle and then the individual muscle fiber cells, we're going to see the nerves follow a similar kind of structure, because one of the things that we need to appreciate are that peripheral nerves and spinal nerves are not one individual axon traveling all the way down. Rather, it is a bundle of many, many different smaller axons. So we're going to start off with first looking at the outer layer here that we call the epineurium. Now, the epineurium is going to be the thickest and mostly full of collagen. Just underneath, we have the perineurium. So the perineurium are going to help divide all of the axons into smaller bundles or smaller fascicles that we see through here. And these smaller fascicles will then have the endoneurium found within it. The endoneurium being that little connective tissue cover that surrounds each of the Schwann cells that we see all throughout here. And of course, when it comes to those peripheral nervous system nerves, we need to appreciate as well that they are going to be single continuations of an axon all the way down the length of the nerve. So some of them can be quite small. However, some of them can be quite large. Some axons can be extremely large, up to 1.5 meters for some people in the case of the sciatic nerve. People come into my office all the time with low back pain and they go, I've got sciatica. And I go, well, okay, let's take an exam. And turns out they don't have sciatica. They just have localized back pain. But, everybody calls it sciatica. So that's neither here nor there. Anyway, so in the terms of the sciatic nerve, that is going to be an area where we have very, very long axons that travel down the posterior leg until it reaches the bottom of the foot. And of course, when it comes to the spinal nerves, we do need to also appreciate that this is going to include the spinal nerve roots, which are going to have both our sensory nerves and our motor nerves in the posterior and anterior roots, respectively. But then when it comes to the structure of the spinal nerve as it leaves the spinal column, so this section that we see right here, do you remember from our skeletal unit when we talked about the intervertebral foramen that are formed when each of those individual spinal segments form or sit on top of each other? We, of course, have the vertebral foramen, the large one in the middle, where the spinal cord resides. And then we have the intervertebral foramen, which exists out here on the sides. That's going to be where the spinal nerve actually exits, which is right about here. So that's the boundary that we're looking at. So everything on the right of my pointer right here is going to exist outside the spinal column, and everything on the left in here will reside inside the spinal column. But when those structures exist outside the spinal column, they are going to divide into a couple of different sections when we are here at the thoracic spinal nerve, or the thoracic spinal column here, because they are going to divide into the posterior ramus, which is going to be the portion of the nerve that branches off posteriorly, the anterior ramus, which is going to be the portion of the nerve that branches off anteriorly. And then we have this section that we find out right here, the rami communicantes. The rami communicantes is going to take all of the autonomic nervous system fibers and take those off to the anterior side where they can then innervate all of the visceral organs found in the trunk anterior to the spinal column. And there's going to be two different sections. We're going to see it divided into, of course, the sympathetic and parasympathetic regions, as well as the afferent and efferent regions of those autonomic fibers. But for the sympathetic section of the autonomic nervous system, we are going to see those fibers have a ganglion out here, a collection of nervous system cell bodies that we see right through here. Now, this is going to be a big reason for why our fight or flight response has a quicker activation time than the parasympathetic division. Because when we go into fight or flight response, think about it. When you feel intimidated or you feel excited or anxious and you just get into this really hyped up state where you think I've got to make a move, I need to be ready to go. That happens rather quickly versus when it comes to trying to calm down, especially if it's finals week, if you're very stressed out and you're in that sympathetic fight or flight state, it's quite difficult to calm down and it doesn't happen right away. It takes a little bit of time. And it's because the parasympathetic region does not have that area of synapsing in the ganglion. So the parasympathetic division is going to follow more of the unmyelinated axon division and have a slower rate of transmission of signals, which is going to be opposite from the sympathetic division instead. Dermatomes. So dermatomes are going to be the references that we use when each pair of spinal nerves supplies the sensory reception to a specific area of skin. Now, some of the dermatomes will have a slight amount of overlap. However, the reason dermatomes are going to be clinically significant is when it comes to musculoskeletal practice, we want to make sure that we're using our understanding of dermatomes to indicate to us whether or not there is going to be some sort of interruption to the functioning of each level of the spinal cord, such as when it comes to certain types of trauma. Now, the way that we're going to look at this is that each pair of spinal nerve roots will, of course, correspond to a similarly found region along the spinal cord. So, for the most superior portions of spinal nerve roots, those are going to provide the innervation or the sensory reception of the skin found on the back of the head. For the skin found on the front of the face, this is actually going to correspond to what we call the trigeminal nerve of the cranial nerve group, which we'll talk about in a future chapter. But as we take a look down further along the rest of the body, we can see that the dermatome activation for the upper limbs will, of course, come by way of those that we find in the cervical spinal cord. You see how we have the activation zones for C4, C5, C6, C7, C8, and T1 being found along the upper limbs. And so on and so forth as we move down the trunk of the body. How we have the sensory dermatomes are supplied by those nerve roots that we find around the trunk of the spinal cord, and so on and so forth down to the lower limbs. Trace the pathway that sensory information is going to follow when it is traveling up into the spinal cord. So the first thing to note for our graph is that we need to take a look at the key over here, noting that those signals shaded in blue will be our somatic sensations, so sensory information from the skeletal muscle system, as well as our exteroceptors and our proprioceptors. So when it comes to breaking down what those words mean, exteroceptors are going to be picking up information from the environment. So let me go ahead, let me break out my terrible writing here and see if we can put that down Environment. That's horrible. We'll stop right there. Enviro, meaning environment. That is going to be what we are picking up on with exteroception, so stimuli outside of us. When it comes to interoception, we are talking about stimuli from within our own body. And then proprioception, this is going to be the type of sensory information that refers to where our joints are positioned in space without actually having to look at it. So this is going to be the type of sensory process that allows us to look at things and be able to interact and coordinate the motion without having to look at it. Like when you're sitting down and you're studying and you're looking at your computer screen or your textbook and you feel thirsty, so you reach for your drink just off to the side, and without actually needing to look at your drink, you can still pick it up and take a drink out of that cup without spilling it or without having any type of dysmetria as a result. That is what's being carried out by our proprioception. So, to move on here, our information shaded in orange is going to be our visceral sensory information that we see right here. So that's the interoception. So we're going to end up seeing sensory information from both our interoceptors of the back, especially when it comes to the skin, and then the exteroception and proprioception coming from the back, from the sensory stimuli being picked up from the receptors in our skin, like free nerve endings, Pacinian corpuscles, Meissner's corpuscles. You remember all of those, right? And then the proprioceptors of our skeletal muscles as well, things like our muscle spindles and the Golgi tendon organs. Those are going to be the primary portions of skeletal muscle that deliver proprioceptive information. So now all of those sensory stimuli are going to travel up the peripheral nerves through the afferent ascending pathways as they reach the posterior ramus, the anterior ramus, and the anterior root through the sympathetic nerve as well. And they are all going to conjoin at the spinal nerve. And once they do at the spinal nerve, they will then differentiate and branch off to travel down the posterior root, or up the posterior root rather. When they are traveling up the posterior root, you will see this portion that we see right through here, this little bump. This little bump indicates that there is a synapse happening. The synapse, of course, like we've discussed in our previous chapters, is going to be where we see the axon terminals of those nerves delivering the information will then synapse with the new cell bodies of the receiving neuron cell. And they will then continue on the action potential and continue the propagation through the posterior root, where it will then be sent to the posterior gray horn, and the posterior gray horn will then take this information, and this is not included in this picture, but the posterior gray horns will take this information and send it to the corresponding white matter tracts. Once it is sent to the corresponding white matter tracts, that information, let me get my pointer, it goes up all of the different rami into the spinal nerve, synapses at the posterior root ganglion, goes up through the posterior root into the posterior gray horn, and is then sent off to the corresponding white matter tract, which will then carry the signal up the spinal cord in those heavily myelinated axons up to the brain for processing. The converse here and trace the pathway of motor information. So of course motor information, because it is part of the efferent system, it is going to be a descending signal which will start in the brain, up in the cerebrum. Now, as all of this motor information descends down the spinal cord, it will descend in the corresponding white matter tract of the spinal cord, where it will then be transferred to the corresponding motor nuclei found in the anterior gray horn. Once all of that information is synapsed, we are then going to, of course, see the information be divided again into our somatic motor commands, the skeletal muscle motor commands shaded in blue, as well as the visceral motor commands shaded in orange. So those are going to be those autonomic motor commands that live in that lateral gray horn. So all of this information will then go out the anterior gray horn through the anterior gray rootlet into the anterior root, where the information will then be collaborated here at the spinal nerve and then sent to the corresponding rami, either the posterior rami, the anterior rami, or the rami communicantes, in the case of things such as visceral motor commands. All of this information will then go through various different processes. We can have a synapse at the sympathetic ganglion, where the information will then be propagated out to our visceral organs via the sympathetic nerve. We can also see through the anterior ramus motor information being sent out to the skeletal muscles of the trunk and the limbs. And then through the posterior ramus, we have motor information being sent out to the back, especially the skeletal muscles of the back and the smooth muscles and glands of the back as well. Now, before we move on, just to clarify, because we do have this synapse of information at the sympathetic ganglion, we do, of course, change from our orange color, which is going to carry our autonomic information in the preganglionic sympathetic fibers. And then we have information after the synapse being carried by the postganglionic sympathetic fibers. What the term postganglionic means is simply that this is the information which has already gone through the synapse of information at the ganglion in the peripheral nervous system. That's all that really means. So we see the different colors of orange to black, but really it just means, is the information synapsed at the ganglion or is it not? Crucial concept of spinal nerve anatomy is to note that spinal nerves form what are called nerve plexuses. A nerve plexus is going to actually be where a series of spinal nerves will exit the spinal column and they will conjoin, they will mingle together at various different levels throughout what is called a network or a plexus. We have four main plexuses in the body. They're going to be the cervical plexus, the brachial plexus, and the lumbar plexus, as well as the sacral plexus. The lumbar and the sacral plexus actually have quite a bit of overlap between the two, so we tend to call them collectively the lumbosacral plexus, to be short. When it comes to the thoracic nerves, though, these do not form a plexus, and it has more to do with skeletal anatomy than nervous system anatomy, because the thoracic nerves will travel along the body in between the ribs. They're what are going to be known as the intercostal nerves. And because they have the ribs separating each of them, it's very difficult for them to cross over and combine. So that's going to be why we don't see a plexus in the thoracic region. Now, the reason the body has these various types of nerve plexuses is because it includes a safety network in the body known as redundancy. This redundancy allows so that if we do see damage to one area of the spinal cord, just one area, there's going to be a fair amount of redundancy throughout the rest of the plexus so that we're going to end up seeing minimal changes to the functioning of the peripheral nerves as a result. This is a very, very good thing. Now, before we move on from this slide, there's a couple of key branches of each of these plexuses I want to point out. When it comes to the cervical plexus, branching off of the C1 through C5 nerve root pairs, This is going to be the area for which the phrenic nerve actually branches off. The phrenic nerve is going to be vitally important to our survival because the phrenic nerve is going to be what powers the thoracic diaphragm, the primary muscle that drives our ability to breathe. Now, an easy way to remember that the phrenic nerve specifically branches off of the nerve root pairs of C3, C4, and C5 is to think of an easy saying. And this saying is that C3, 4, and 5 keeps the diaphragm and you alive. Remember that. C3, 4, 5 keeps the diaphragm and you alive. When it comes to the brachial plexus, this is going to be the area which branches off of the nerve root pairs C5 through T1 on both sides of the body. And this is going to be the area that gives us nerves such as the musculocutaneous nerve, the axillary nerve, the radial nerve, the median nerve, and the ulnar nerve. These are all going to be key nerves which power all of the muscles of the upper limbs, especially when it comes to the muscles of the rotator cuff and the rest of the arm. The lumbosacral plexus next is going to be the area of the body which gives rise to important nerves such as the ilioinguinal nerve and the genitofemoral nerve. As the names imply, the ilioinguinal and genitofemoral nerve are going to be nerves that innervate more of the anterior side of the lower trunk, especially when it comes to the genital and femoral regions of the body, especially such as the anterior hip. The femoral nerve and the obturator nerve can also be found branching off of this area of the spinal cord because the femoral nerve is going to be crucial in driving the musculature found on the posterior thigh. We're also going to see key muscles here, like the sciatic nerve branching off of the lumbosacral plexus that we see right here. The sciatic nerve is going to carry innervation from branches of L4, L5, and S1 most specifically. There are going to be some variations based on individual anatomy, but those are going to be the most common branches that contribute to the sciatic nerve. And this is going to be the largest nerve that is going to power a lot of the musculature found on the posterior thigh, as well as in the calf and the foot. Looking above the sciatic nerve, we can see that the lumbosacral plexus will also give rise to nerves such as the superior gluteal nerve and the inferior gluteal nerve. And as the name implies, these are going to be the nerves that will help drive the gluteal muscles, which is a big reason why we want to keep this in mind from a clinical perspective, because if we see a patient walk in with hip drop or the inability to contract the gluteal muscles on one side of the hip, especially the gluteus medius, this is going to be an indicator that we may be suspecting, or we may need to suspect, to look at the health of those superior and inferior gluteal nerves. Gears next and talk about reflexes, because reflexes are going to be an essential part to the maintenance of our homeostasis. Reflexes are going to be different types of responses that allow for the body to make quick responses, rapid automatic responses to various types of stimuli without needing to really focus on involving the brain and involving any type of processing, because that can take time. And what we do want to see with reflexes is very quick and rapid responses that allow us to act in case of danger very, very quickly. The steps of a reflex are going to involve the activation of a sensory neuron, the involvement of an interneuron in the spinal cord, and the response of a motor neuron. So we take a look at it in this chart over here on the right. We of course have the stimulation of a receptor the sensory neuron, which is going to carry information up into the spinal cord where it synapses with an interneuron. And that interneuron is then going to send an automatic response through the motor system down to activate the effector, in this case, a skeletal muscle fiber. So in this specific example, we'll talk about the first step here is going to be the activation of a receptor by a stimulus. We'll use a painful stimulus in this point here. Leaning on attack stimulates the pain receptors. We can also talk about, stepping on a Lego, if that is going to be our new stimulus. So we have some sort of painful stimulus activating the initial part of our reflex. That receptor will then send the signal through our sensory nerve, where it will then synapse in the posterior root ganglion, and then sent through the posterior gray horn. Once it is sent through the posterior gray horn, the signal will then synapse with the interneurons. The interneurons will carry that signal and create an automatic motor response sent down that anterior gray horn. Of course, the brain wants to be aware of all of this, all of what's happening, so part of the information will then be, of course, transmitted to the higher order processing centers of the brain. And then, of course, this will involve the activation of the motor neuron, which will then send an effector response or an efferent response. This efferent response will then be sent to the effector, in this case, skeletal muscle fibers. The effector can be other things as well, such as various types of glands and an organ in total. But the effector is simply going to be the one that is creating the change, in this case, the contraction of the biceps muscle to remove our hand from the painful stimulus. Now, like with everything else with anatomy and physiology, we love our different classifications, love to create tons of categories because it keeps everything nice and neat. So we categorize different types of reflexes in a couple of different ways. We can have them based on our overall development. Are they an innate reflex, something like we would call the Moro reflex or the shock reflex, or that feeling of trying to contract and protect yourself in the instance of dangerous stimuli? Another type of innate reflex would be something like a rooting reflex. So in the case of a young infant, a rooting reflex would include something like brushing lightly the side of their cheek, because the infant, as part of the rooting reflex, when it feels a light stimuli on the side of their cheek, the infant will then start to pucker their lips and start to actually look for an area to nurse milk from. Then we have other different types of acquired reflexes that we develop later on in life. And then we classify the nature of our response, or the nature of the response, for different categories of different types of reflexes. We have a somatic reflex, which would be like what we talked about in our previous example, the painful stimuli creating a somatic response, the contraction of that biceps muscle to help avoid the painful response. We also have visceral types of reflexes, like we see with the ocular cardiac reflex. So a visceral reflex is instead going to involve, rather than the effector being a skeletal muscle fiber, it can involve a visceral organ, like with the ocular cardiac reflex. With the ocular cardiac reflex, this is going to involve a reflex that starts with an increased amount of pressure on the eyeball. This increased amount of pressure on the eyeball is going to stimulate what is known as the trigeminal vagal reflex, where the trigeminal nerve will then take the afferent response and send it down the vagal system, down to activate the effector, which is the heart. And this pressure on your eyeballs is actually going to decrease your heart rate and decrease your total cardiac stress. It's something that we actually tend to innately activate on smaller levels. If you've ever felt that kind of stress during midterms or finals week and you're feeling overwhelmed and then you kind of just lean over and then you just rub your eyes a little bit, that's actually the body innately trying to get you to activate that ocular cardiac reflex to help increase a small amount of pressure on your eyeballs by way of rubbing your eyes, and to then initiate a very small adjustment to your cardiac stress. It's a really, really impressive thing that the body is capable of doing. And then, of course, we classify reflexes on the complexity of their circuit. We have monosynaptic reflexes, such as what we see through our example right here, through our somatic reflex. And then we have polysynaptic reflexes. Polysynaptic reflexes are going to be more common with our visceral types of reflexes because we end up seeing multiple systems involved with our visceral types of reflexes. But of course, another excellent example of our monosynaptic reflex would be something like a stretch reflex, like we see for a knee jerk or a patellar reflex. And then, of course, we classify reflexes based on where the processing is going to be happening, whether it is happening in the spinal cord, like we have seen with all of our previous examples of a somatic reflex, a somatic monosynaptic reflex, and then we have our cranial types of reflexes. Those are going to be the ones that are more complex and carried out by the rest of the cerebrum instead. A good physical exam of our patients will, of course, include assessing reflexes because assessing reflexes will give us tons of information about their nervous system as well as the musculoskeletal system. And when it comes to the biceps, triceps, ankle jerk, and knee jerk reflexes, these are all known as stretch reflexes. So these are going to be where we take a typical reflex hammer that we see right here, and we are simply going to tap the reflex hammer on the tendon of the associated muscle we are testing. So of course, biceps tendon, triceps tendon. With the ankle jerk tendon, or the ankle jerk reflex, we are testing the Achilles tendon. So that is why the ankle jerk reflex is also known as the Achilles reflex. With the knee jerk reflex, we are of course going to strike the hammer on the patellar tendon, and is a big reason why we call it the patellar reflex. Now, this quick tap on the tendon is going to change the length or change the contraction of the muscle on a small degree, and it is going to elicit an efferent response where the skeletal muscle will then contract in the effort of trying to protect the body against this random stretch stimulus. So this is going to give us the ability to grade a patient's reflexes and give us plenty of information about what is happening to their corresponding spinal segments. Such as when it comes to the ankle jerk reflex, this is our typical way of evaluating the S1 nerve root pairs. When it comes to the knee jerk or the patellar reflex, this is an excellent assessment of the L4 spinal nerve root pairs. Separate type of reflex that we use to assess nervous system integrity is going to be the Babinski reflex. The Babinski reflex is not going to be a stretch reflex. Instead, it is going to give us an idea of the degree of myelination or the health of the nervous system of our patients, because what we need to realize is that, first of all, what we do with the Babinski reflex is we take the opposite end of the reflex hammer, the one with the sharp point, and what we are going to do is stroke up the lateral side of the foot. Now, of course, when it comes to clinical neuroscience, we want to make sure that we are going up the lateral side of the foot and also tracing across the metatarsal heads. That is a key distinction that is not quite included in a lot of various types of examination trainings, but when it comes to a proper neurological examination, we want to make sure that the Babinski reflex includes taking the sharp end of the reflex hammer, tracing up the lateral aspect of the foot and across all of the metatarsal heads. Now, a Babinski reflex can vary based on the age of our patient. When we have a patient under the age of 1, their nervous system is going to be rather not so heavily myelinated. And as a result, when we do the Babinski reflex on an infant or a child under the age of 1, we will see a response of this infant where they will actually bring their toes upward and they will just spread them apart. That is a normal response in an infant under the age of 1. However, around the age of 1, the rest of their nervous system tracts will begin to form correctly, and they will begin to reverse the response in a healthy individual. This reversed response will then we will see the patient actually curl their toes downward in a healthy response. Now, when we see an adult or any patient over the age of 1 and we do a proper Babinski reflex and they actually have the upgoing toe where their toes splay out, fan out, like we see right here, this is going to indicate us with very, very high probability that this patient is suffering from some sort of injury, insult, any type of problem to their nervous system. It's going to be one of the most accurate ways that we can define that a patient has an issue with their nervous system is through a positive Babinski reflex. And then, of course, now we have our chart of all of our different most common reflexes that we use in the body. There are going to be plenty of other types of reflexes as well. We have the blink reflex is one that is not listed on this image right here. The blink reflex is going to be an excellent examination of the cranial nerves 2 and 3, the optic and oculomotor nerves. But when it comes to the reflexes that we see down here under the stretch reflexes, these are going to be ones that should be included in virtually every single physical exam in which we suspect some sort of injury to the nervous system or the musculoskeletal system. When it comes to the superficial reflexes, we want to make sure that we are using these more discriminately, making sure that we use them in proper situations, of course. For instance, if we have a patient that is experiencing, you know, here's a classic example. They went and they had a skiing accident, and there's a possibility that they have a compression fracture of the thoracic vertebral segments, and we are trying to determine whether that might be an issue. We want to be using the abdominal reflex for this patient. We do not want to be using the anal reflex for this patient. If they didn't have a blunt force trauma to the pelvic region, there is no reason to be putting this patient through an anal reflex test. So please, please, please make sure you are being very judicious about how you utilize the testing of these various types of reflexes, whether it is superficial, whether it is a visceral reflex, all of these different things. Make sure that you're being or choosing the appropriate test for that patient's situation. Well, that's going to cover it for our Chapter 12 discussion about the spinal cord and reflexes. So I will be back with our Chapter 13 discussion, talking about the cerebrum, the rest of the structures of the brain, and its overall physiology. In the meantime, everybody have a wonderful rest of your weekend, and I'll see you soon.